Hi, good morning, everybody. Thank you for having me here to share. Today's session will be quite short because it's impossible to deal with all the emergencies, but I hope to empower each of us with an overview. And I must qualify this is only from our experience or limited experience, but we have found this approach to be very helpful. When we first started chronic ventilation at home about 10 years ago, the idea was very scary to everybody. So doctors and nurses didn't believe it would work, and patients and families were horrified. If you remember the pirate movies, the pirates, once they capture a ship, they'll execute the people they captured by making them walk the plank. So, you are walking off a narrow swinging board and dropping off into the dangerous unknown. This is how patients and families feel. I believe strongly that our role as home care professionals, as healthcare professionals, is to help patients to navigate this. And so going home should be a comforting rather than a scary experience. And in order for that to happen, they need to be equipped for it. Okay, I come back to this picture. This is Dr. Bjorn Ibsen, my hero. He's a Danish anesthetist who saved a lot of lives of polio patients by instituting positive pressure ventilation, here performed by hand by a medical student on this little girl via a tracheostomy. Okay, so I put this picture here because when our chronic ventilation patients go home, the immediate life-threatening things to them would be the airway and the breathing. And therefore, being able to empower family members to recognize the emergency and to institute the correct measures is very important. Okay, so this is what we'll be doing. We need to empower the patient and family to recognize that there's an emergency. After that, they need to know whether they can perform the immediate remedy at home, and then should they go to the hospital or should they stay put. And it's very important because sometimes the emergency is inevitable. It is the terminal event. In the case for them to go to emergency department, to be isolated from the family while they are in the resusc room, and then after heroic efforts, they pass away in pain and alone and in fear. I think that is not the right thing to do for those patients, especially if they have indicated that what is important to them is to be surrounded by loved ones, to be pain-free, and to be comfortable, right? So I think it's important that we help them to recognize which are the emergencies, and then to provide the decision support about whether to choose palliative care at home at that point or to go to the acute hospital. Okay, so I've mentioned this already in my slide, previous slide. This is prevent the emergency if possible, and then prevent harm from the emergency. But if it's not possible, then to ensure that the patient receives adequate pain relief, comfort, and most importantly, being accompanied by the loved ones, the meaningful ones. So the biggest tragedy in COVID is that every day we see patients dying alone. And I'm moved by the heroism of our nurses. Actually, the doctors do very little. We just go there, we see the patient, we order some drugs, then we walk away, we sit outside the computer. But the nurses are the ones who are in the room. And then what moves me always is when the patient is, actually a patient is sedated, paralyzed, and the family just wants to see the patient the last time, and the nurse will hold the phone up so that they can FaceTime for the family to see the patient. So accompaniment is very important for the dying person, and accompaniment is also very is a closure for the family members, and we need to ensure that. So, but in order for patients and family to be able to prevent emergency and to prevent harm and to recognize that this could be salvageable or this could be a final event, the patient and the family need to learn a bit of medicine, a bit of nursing, and a bit of therapy. So that's something that we need to teach. And the Latin word for doctor actually is, the root word is docere, and docere is to teach. So as doctors, you and me, our first job is to teach. The body, we're born in this body with this set of chromosomes, and then we live 70, 80, 90, or 100 years, and one day we'll pass away. We have sicknesses, probably half the sicknesses you get well, or more than half you get better by yourself. And you know the number needed to treat for each drug may be like 10 or 15. The number needed to harm may be similar. So actually, as a doctor, what is our main role? Is it to give that pill that will really make such a difference, give that injection that makes such a difference? Oftentimes is to teach the patients to recognize where they are and to choose. Okay, so our role is to teach, and we will be letting down our patients if we don't do that. Nursing, of course, is the first healthcare profession that really accompanies the patient. So from the days of Florence Nightingale, nurses accompany the soldiers, dressing their wounds, palliating their pain, and holding their hands when they're dying. Family members need to learn how to do that. How many of your family members are scared of blood? They see a tinge of blood in the sputum, they freak out and panic. We need to guide them and slowly teach them that it is okay. Because if the spouse or the son or the husband panics, the patient will panic even more. We need to teach our patients also the practical nursing skills, how to dress the wound, how to measure, how to feed medicine, and do all this correctly. And lastly, therapy. So like moving the joints, safe transfers, chest physiotherapy, even speech and swallowing, and speech and language therapy. So all these are things that the family members and the patients themselves need to learn and understand, and this is what we need to do. So I guess that is the spirit behind this whole series of MND Beyond Borders. So what we need to do is to teach in a way that the patient and family can understand. So how many of you can remember you go to med school or to nursing school and you don't know what the teacher is talking about. They just go on and on and on. Then you fall asleep or you close your book and you go daydream. But then later you find a friend who's a senior, maybe who can explain to you the concept in a way that you can understand, and suddenly enlightenment. That is what we need to do for our patients and family. Anatomy and physiology. Okay, so we don't need to teach anatomy in Greek. You can teach in English, in Bahasa Melayu, in Chinese, in Hokkien. We need to teach pathophysiology. You need to teach pathophysiology also. So what goes wrong? When you have motor neuron disease, what happens? Your nerves in the brain and spinal cord are affected, and therefore your muscles are weak. When your muscles are weak, you have a risk of falling down, you have inability to cough out your phlegm, your speech becomes poorer. So that's pathophysiology. These are some things that generally are not taught in Singapore. Outside of HURSS, I don't see doctors and nurses teaching patients and families, but this is absolutely critical. And we learn it along the way, even as early as 2010, 2011. Simple physical examination. I'll go through some examples. And care tasks and equipment, everybody teaches. So, there's a checklist. The nurses will have a checklist. Tick, 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 tick. You are competent. If you can do that care task once, does it mean you really know how to do it? Will you still be able to do it 3 weeks later? Will you be able to do it if you turn the bed around and then the ceiling light is now here and the PowerPoint is a bit further away? Right. So when we teach care tasks, we need to let them internalize it, understand the meaning behind the task, the purpose, and how to improvise. So the example I always use is for young fathers. Parenting doesn't come natural to us. The first time you change a diaper full of shit, what do? And the 50th time you change it, you probably have done it differently from what the midwife or the nurse taught you, right? We need to teach our patients and families how to do the care tasks. And lastly, emergency drills. Recently, to my horror, I received a phone call. So there was a patient's mom. She's an excellent carer and she has looked after her daughter so well. But I think we, the care team, the professionals, we have become complacent. We assume that she is very skillful, so we have not revised embryo bagging for a long time. Then one day her daughter had a profound desaturation to 70% and then to 30%. And she panicked, she called us. And then over the phone, we were trying to go through the basics. So we're trying to go through asking her to elicit some physical signs. And then lastly had to walk her through taking out the embryo bag, assembling it, and hand ventilating her. We saved an admission. She didn't come to ED. She settled her problems. And then with a bit more humidification, subsequent increased frequency of cough assist, we solved the problem. Otherwise, she would have come to hospital. And, in this pandemic situation, what happens is that she would be stuck in ED for many, many hours. And sometimes bad things happen to patients in ED. Then she would be isolated for 36 hours while waiting for COVID sorts to be negative. And again, bad things happen to patients during that time. And then, the mom can only visit for 1 hour a day for many days after that. So this is what we need to teach. And when we teach it properly, the patients and families benefit. Okay, so I'm just going to go through about the next 15 minutes, 6 or 7 organ systems that are critical. And of course, number 1 is airway and breathing, not because I'm an anesthetist, but because airway and breathing are really the number 1 things that can kill you in minutes. Okay, so I'm very aware that in Malaysia and Indonesia, not so many patients have got tracheostomies, but these two are rapidly life-threatening. Dislodged tracheostomy, if the patient is vent dependent and you do not know how to do rescue breathing through the natural airway or how to reinsert the trachea. NIV failure could be due to discoordination of the bulbar structures. So the tongue, the vocal cords, the epiglottis, and then that leads to increased leak or increased impedance to the airflow. Ventilator failure could be the machine failing itself. Patients always panic and freak out when they see blood streaks, but you need to distinguish between just simple minimal streaking, which is probably self-limiting, some degree of blood stain secretions, which could portend a bit of respiratory infection and bronchiectasis. Very common causes also could include like deep tracheal suctioning causing erosions in the tracheal mucosa. You need to distinguish this from the life-threatening hemoptysis that can happen, right? Which if you have a trachea, it could be due to a tracheal innominate fistula, or if you don't have a trachea, the patient may have some structures in the lung that are now, massively hemorrhaging. And lastly, foreign body aspiration is also a common life-threatening emergency. Okay, for these emergencies, all are very frightening to the patients and the family. So I think it's important to constantly go through with them, both before discharge, during your first home visits, during subsequent visits, go through and then try to put it into such a way that the patients and family understand the gravity and yet do not panic and freeze. We don't want a freeze response. Okay, I find it helpful to go through anatomy and physiology this way, explain to them why we breathe. These are the physiological reasons why we breathe, because the body needs to regulate these. These are the structures, so the upper airway and how it can either block, collapse, or become discoordinate. These are the breathing muscles, so not just the diaphragm, but all the rib cage muscles, the neck muscles, the abdominal muscles. Then what can go wrong along the medium, small airways, all the way down to the alveoli, right? So I often use this picture in sharing and teaching my patients. This is another very helpful picture to explain, and you can get a reference here, okay? To explain how the non-invasive ventilator works. So essentially, you have something that's blowing air. So it's important to tell them that you are blowing air. Pardon me, I hate it when some ward doctor, sometimes even consultants, tell the patient, I give you this machine, it blow oxygen into the patient. Then I roll my eyes. Blow oxygen, come on, which planet do you come from? Okay, so we have to be precise in our language. So the machine blows air. Why is this important? Because when all else fails, you can do mouth to mouth and you're blowing oxygen poor air, 16% oxygen, but it's still life-saving, right? So the ventilator blows air. And all of you will remember from your BCLS days that we must open the airway. So you must hit your chin lift, open the airway, because upper airway collapse will make this useless. It's important to recognize that there are leaks that are built into the NIV system, so both into the mask or into the tubing, but there are also leaks that come either with disease progression or because of poor fit of the interface. Okay, so with this, you understand that we are blowing air into the trachea, but you need to overcome the leaks and overcome the upper airway obstruction. Then after that, air gets into the lungs. The airways may provide resistance. The lung may be stiff. There may be air or water outside the lungs. And whatever you blow will only do its work if we overcome these two. So it's helpful to teach them this. It's helpful to teach them how to monitor effectiveness. So you remember, your professor in medicine may have taught you, go to end of bed, squat down, look at the chest rising equally. You then go to the patient's side, put the hand on the upper chest, put the fingers around the ribs and the thumb in the midline. I've reversed this because I'm sitting like that. It should be like that, right? So all these are things that we teach the patients and family. I don't always ask them to buy a stethoscope, but for the more intelligent and motivated family members, usually by the second or third home visit, I encourage them to buy a stethoscope. Then I may first lend them my stethoscope, ask them to listen to themselves, listen to the patients. Then I say, you just listen every day. One day when you hear something different or you don't hear anything at all, then you know that that's important and you quickly call us or you call 995 if it's an emergency and we are not able to respond in time. Okay, so this is more of the same, explaining the anatomy and physiology. When we come to ventilators, ventilator manufacturers always try to confuse us with a lot of terminology, but it's very important just to realize that at least for chronic ventilation, it's very simple. There are only two types of modes. There's the pressure limited and the volume limited. Most of your ventilators are pressure limited. So BiPAP, PSP, even your AVAPs or IVAPs. Because AVAPs or IVAPs, although we have a so-called tidal volume, but that is a desired or target tidal volume. It's not a set tidal volume. The machine somehow monitors and thinks that is giving this tidal volume, but what the machine actually drives is the pressure difference. Okay, so when you have a pressure limited mode, you have an inspiratory pressure, expiratory pressure. The difference is the driving pressure, and this is constant, or it changes slowly if you are using a volume targeted pressure limited mode. It changes a little bit, but it's largely still fairly constant. So what you'll be looking at is the tidal volume. Okay, a drop in the tidal volume with the same driving pressure means that it's either leaking out and therefore not getting the lungs, or there's stiffness in the whole respiratory system. And stiffness could be due to airway resistance or collapse, or you could be due to lung structures or pleural structures, right? And chest wall structures that are limiting it. Okay, in terms of the tidal volume change, I think depending on the particular ventilator you're using, for some patients, if you have a small to moderate leak, some brands of ventilator may actually show paradoxically an increased tidal volume. That's because the ventilator blows more to compensate for the leak, and then it imagines that the tidal volume is larger. I mean, imagine it's a loose word, the machine has some algorithm to calculate. Okay, so important thing is to always teach your family members, don't just look at the numbers, also correlate with the chest excursion, and better still if you have a stethoscope, the air entry. Okay, don't just look at the numbers on the screen. But so this is true for maybe 70 to 90% of the ventilators we use. We rarely use volume targeted modes like strict volume control ventilation. I mean, that was fashionable in the 90s to the early 2000s. And for some good reason, some specialists still recommend using volume limited modes, but they are less comfortable for most patients and not really necessary. For this, the important thing is you realize you are giving a volume. So if you give a volume and the passageway is very narrow, the pressure will shoot up. So a high pressure alarm will tell you that there's some kind of obstruction or there's a lot of stiffness. There's a decreased compliance there, and therefore you have a high pressure. Okay, but if you're using a pressure limiter mode, no point looking at peak inspiratory pressure, it's going to be the same, right? Or you'll be low because there's a leak. So volume limited mode, if you have a low pressure or low high volume, then it does tell you that it's a leak. But it's a high pressure, it means it's a system compliance problem. I go back to about 2012. We had one young ALS patient. He was using a nasal pillows, and he could still talk with the mouth, continuous ventilation through the nose. And he had very clear-cut intention not to progress to tracheostomy because he didn't want to spend all his savings. He had a young wife and a young daughter. This gentleman, one evening, Okay, we'll come to structure of your service later, but in those days, it was just me, Anura, our RT, and one nurse. But that evening, the wife called me panicking, and this was her message. My husband is very uncomfortable. SpO2 is very low. What should we do? In the background, you could hear a whoosh, 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 whoosh. So I was thinking about it, and then I spoke to Anura. We actually did a independent calls to her to troubleshoot. And what we realized, we thought our diagnosis was actually that the jaw muscles that keep the mandible closed, the muscles that close your mouth, have weakened. So the jaw was dropping open. And somehow when you use a nasal interface, actually the pressure will push the uvula against the tongue. So it seals, and from the nose, you have a kind of a closed passage to the glottis. But in this case, the uvula to the tongue seal wasn't good enough. The mouth was open, and the ventilator didn't know when to cycle off because it was a PSV kind of mode. So it keeps going whoosh, 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 trying to push. So this illustrated in this picture, which is shown. This article is from BMJ Thorax. I'm sorry, I don't have the reference here, but you all can contact me. I can send you the original article, or I send to Shu Xian. So this is a flow time curve. So the machine, you remember from the ventilator lectures that for flow cycle modes, right, the machine will push to a certain pressure, but when does it cycle off? It cycles off when the initial flow, when the flow drops to a fraction of the initial flow, right? So like, let's say we set 25% of initial flow. This is the initial flow. Then when the flow drops to, say your initial flow is 100 liters per minute, it drops to 25, then the machine will stop pushing, and then you can exhale. So if all of you take a deep breath out, you realize that when you first start breathing, the airflow is faster. If you put a feather next to your nostril, you can see that. Then as you inhale, the respiratory system impedance increases and the flow slows down. Okay, so that's what's happening. But in this case, the nasal interface and the open mouth, the flow never really drops. So the machine doesn't know how to cycle off, when to cycle off. So it keeps pushing, and the poor patient wants to exhale, but the air is like going round and round and can't exhale properly. Then he panicked, then he dropped his SpO2. So how did we handle it? So that night I asked the wife I said you may have to go to ED, but you go ED, they will definitely ask you, does he want to be intubated and trachea? If he say no, then they'll leave him at a corner and give him morphine to palliate him, and then he may be very uncomfortable and alone. In those days, no COVID, but still the EDs were crowded, busy, and noisy and uncomfortable. And sometimes in the resusc room, they don't let the families in. So I told her, you get a scarf, a nice like Hermes, or one of those fancy scarf, and tie something to close the mouth. And she tried that, and actually it worked. So the ventilator stopped, sort of like alarming. He was able to catch a breath. Of course, he had some standby morphine serum at home. Also asked her to administer some of that. And then he panicked a bit less, breathed a bit slower, mouth managed to close, tighten the scarf a bit. So you imagine it's a scarf here and then nasal interface, and then he could go to sleep. Next morning was a Saturday morning. Again, we'll talk about structure of your service. We were not supposed to work, but Anura and I did an extraordinary visit, and we confirmed our suspicion. So then we asked her to continue using a scarf, but we got the vendor to bring in a chin strap. So after that, we learned our lesson. Most patients get a chin strap. And then we also changed the ventilator to a time mode. So instead of a flow cycle mode, it's a time cycle mode. Let's say blow for 1.1 second, then it will cycle off. So we just tell the patient, you try to coordinate the ventilator. When it blows, you just inhale. Then when you stop blowing, you exhale. And that kept the patient going for another 1 to 2 months. But eventually his bowel dysfunction was so bad, he was very uncomfortable. He was on continuous morphine round the clock. So he admitted himself to a private hospital under a colleague of mine. And he requested for withdrawal of life support then. So in a private hospital, it's easier to do this. So They basically gave him more and more palliative medication, then wind down the ventilator, and he passed away. The end of this story is that actually 6 months later, the wife went into severe depression, and then our social worker had to help organize a psychiatric assistance for her. This is a picture I commonly use, so you can never teach too much. You know, explain how air flows through the nasal passage to the glottis, how saliva is supposed to go behind, what happens when you swallow, the vocal cords close, epiglottis comes down and saliva goes this way, what happens when you have a trachea with balloon inflated, trachea with balloon deflated, and whether it's an open stoma with a speaking valve or ventilator. So make use of tools like this. So I have this photo on my phone. Of course, there are pocket models that you can also buy. I think $200 that show this. Very helpful. Okay, I want to draw attention now to a few things for tracheostomy safety. May not be totally relevant, but just bear with me. But this is from the UK National Tracheostomy Safety Project. So they have a recommendation. And whenever the patient is in any kind of distress and patient has a tracheostomy, the first thing to do is to assess the patency. So look at the yellow ring, okay? Is the trachea patent? And the way to assess patency is whether you can feel air through the tracheostoma after you remove whatever caps or filter there is. And then can you pass a suction catheter? So you remember if there's an inner tube, you also take out inner tube, check and wash it. Then you try to pass the suction catheter through the outer tube. But of course, if it's a fenestrated trachea with a big stoma, then you must put the non-fan inner tube before you try that. Sometimes there's a plug adherent to the tip of the outer cannula. Then you can't pass the suction catheter even though you wash the inner cannula. If that is the case, you deflate the balloon and then see whether a patient can exhale through the nose and mouth. So 2 holes here, right? 1 hole here and 2 holes here. Okay, 3 holes here. If the patient cannot exhale through the nose and mouth despite cuff deflation, then the tracheostomy is blocked. The tract is blocked. And if it's blocked, it's equivalent to a marble or a fishball in the windpipe. It's useless. Okay, so confession time. Prior to 2010, Singapore Ministry of Health had a document for nurses. The document says all these things are, deflate the cuff, pass the suction catheter, then put the patient in a position of comfort. Then it says call doctor, but it didn't elaborate what the doctor is supposed to do. Then we did a straw poll, went around, asked a few doctors, and very few doctors dare to say take out the trachea. Okay, but I want you all to go back and teach all your friends this thing, teach all your colleagues. So whether it's a nurse, an assistant nurse, a houseman, or consultant, if a tracheostomy is blocked, take it out. All right, no questions asked, because if it's blocked and you cannot clear it, it is a fishball or marble in the airway. After you have taken out a trachea, then if the patient has got breathing capacity, you just give oxygen through the mouth and nose as well as the stoma, and the patient can breathe. Then you can send the patient to an emergency facility where they can decide whether to reinsert trachea or something. If the patient is like your MND patients who are too weak to breathe, then you need to cover the stoma and you need to open the upper airway and ventilate through the mouth and nose. Okay, so a tracheostomized patient still need both bag and mask to go with them everywhere. They cannot just bring the bag, because if they just bring the bag and the trachea drops out and they don't know how to put it back, then you can't ventilate the patient. Right? Then you have to do mouth to mouth and while closing the stoma. Important to drill that into your patients and family, those patients with the trachea. So in a nutshell, this is what will tide you through until you get to ED, and then expert help is there. Okay, so this is Lydia teaching rescue breathing. So she's speaking Mandarin. And, so she's trying to emphasize the importance of seal and so on. Okay, so I've gone down airway breathing, circulation. Okay, under breathing, things like pneumothorax and all that, it's a bit tricky and quite too much information for the patient. So I think getting them to learn how to do the palpation, be able to tell you which side is moving less. If they got stethoscope, which side has less air entry. and then we will report the volumes and pressures on ventilator screen. Then if there's an emergency, we'll usually walk them through a little bit more. Okay, circulation, the emergencies could be as follows. So it could be a coronary artery disease, severe life-threatening and ischemic heart disease, could be shock from any of these things, could be tachy or bradyarrhythmias. It's a bit harder to teach the family to assess circulation, but some of the basics we teach them will be like how to assess for pallor. So here is this one we actually didn't teach the patient and family, but then they call us and said the patient now has black stool, and we got to decide whether to send the patient to ED straight away or we can do a home visit. So we asked her to take a photo with the mom showing the two palms. So the daughter is very healthy, and if the daughter's palm looks like mother's palm, mother cannot be too sick, right? Then we asked her to quantitate the amount of melena, and then indeed it was very minimal. So subsequently we could visit the following working day, do a full blood count, which showed that HV wasn't too low, started the proton pump inhibitor, and it settled. So it was a gastrostomy erosion. The gastrostomy tip rubbing against the posterior wall of the stomach, causing erosion, causing melena. I find it hard to teach, but I would like to learn how to do so. Cap refill, skin temperature. So these are a bit harder to teach, which I haven't successfully done it. Teaching them how to palpate for edema is possible and doable. So it's something I always do if the patient has a history of renal or heart failure. And then if the patient is dying, you need to teach them where to feel the pulses. Radial, brachial, femoral, and even the apex beat. Because if your patient is on a ventilator, the chest will continue moving. So to recognize when death has occurred, they have to feel the pulse and apex beat. And then when there's no heartbeat, I say wait a while, then you call the doctor to come and certify death. If in doubt, I actually ask them to wait until there's some skin color changes, the livedo reticularis. Because in Singapore, if the GP, house call GP comes and the patient is not dead yet, then they charge you $270, and then they call them again when the patient is finally passed away. Okay, so circulatory assessment is important for this purpose. This is hard to teach, but again, when we are with the family, we always assess the patient's wakefulness, see if the patient can obey commands. If the patient has a cerebellar stroke, we may elicit nystagmus and ask the family to observe. And then things like pass pointing and all these are the cokinesis. So when we do the neurology examination, we ask the family to watch so that they can pick up. And then if they call us, we will be able to make more sense of it. The usual things that we worry about is a new stroke or fall with head injury. Fall with severe head injury is very obvious, coma, BP high, heart rate low. Those is a terminal event or is a cause for ED. But sometimes they have trivial head injury, then you need to teach them to look out for like a chronic subdural. So look for change in mental state a few days or weeks later, and any new neurological signs like weakness. Okay, so all these usually we will not teach before discharge because too many things to learn. But when we do the house call, we always examine the patient with the family around. We never chase them out, and then we will teach as we examine. Okay, gastrointestinal, this is a medical legal pitfall because with telemedicine, the doctor cannot examine the patient. So does it mean that everyone with some gastrointestinal symptom gets sent to ED? So our patients are always constipated. They often have abdominal distension and bloatedness. So we do teach them like how to do a simple palpation. So when we are at the patient's home, we show them, then we may make them do it, and you may have to teach them how not to poke with a fingertip, how to do a superficial and deep palpation, essentially looking out for tenderness and rebound and rigidity. Okay, if it's like bleeding GI, we teach them the significance of the color of the stool and so on. Intra-abdominal sepsis, how the abdominal signs correlate with the circulatory signs and so on. If your patients have gastrostomy, then it's important to look at the baric bumper issue as well as other gastrostomy issues. So this is a picture of a patient where you see a marking is at 1 cm, this is 2 cm, so it's a 1 cm at the external retention ring. It's like 0.5 cm here. You can see the balloon here. So what has happened is that the external retention ring has been put tighter and tighter and tighter, and then the balloon has dissected out, pressurized, necrosed, and dissected out, causing a big hole at the exit site. Okay, so in this case, what I did was that I called we were doing a home visit, so I called my gastroenterology friend, and he kindly advised me that to check whether I can move the external retention ring up, push the whole tube back down, and then we tape down the external retention ring, and over a few weeks, the hole healed and got smaller. So we were able to save the patient second procedure, because otherwise you're supposed to take out the gastrostomy, close the hole, maybe do parenteral feeding or jejunal feeding for a while, rest the stomach, then after that reinsert the gastrostomy when the hole is smaller. But that's really a disaster. So one of the things you do if you have patients with gastrostomy is always teach them, if the markings change, alert you. Tell them not to push the external retention ring down too much, and if the skin marking changes, to alert us. Second thing is to prevent traction, excessive traction on the gastrostomy tube. Okay, the other thing that can happen when the markings change is that it could be because the balloon is self-deflating. Sometimes we observe that over a few months, the water in the balloon actually diminishes in volume, the balloon deflates, and the tube migrates, then you move the external retention ring down. So when that happens, sometimes imagine if the balloon is already in the stomach passage, then the gastric part closes, and you won't be able to insert it back in at the bedside. And for those cases, we actually have to admit them, and under interventional radiology, they inject dye, then they pass a wire and reinsert. So it's a lot of trouble, although it's not dangerous if dealt with properly. Urogenital emergency is very common in spinal cord injured, can still happen in ALS, and the number one is acute retention of urine. Okay, so this is a video of me with a patient. Normal urine production in a person is 0.5 ml per kg per hour. So in this gentleman's case, it should be about 40 to 50 ml per hour. It means that in 4 hours, you will have 200 ml. In 8 hours, you will have about 400 ml. Okay. If the urine catheter is blocked, then what you will start to see is that there may be a bit of a swelling around the lower tummy, and the swelling may get bigger and bigger and look like a grapefruit or a watermelon shape. So the way to feel is you put your hand flat on the tummy and just feel gently. So like right now, the tummy is very soft. But if I feel something hard here, the next step is I do what we call percussion. We tap on the tummy. So this is the normal sound of intestines with air in the abdomen. Normal sound. Okay. So this is what we call resonance. So imagine I tap on wood, it is this sound. But if there's a pocket of water in the area, then it will be very dull. You'll be like that. Okay. So if we have the 4 signs together, one is no urine coming out from the tube. Second is patient is uncomfortable. Thirdly, you can feel something here, which is hard. And fourthly, the sound is down. Then it is a blocked catheter. So once we have linked up with Home Nursing Foundation, contact the Home Nursing Foundation nurse to come and change the tube if possible. If they are not able to come, or if it's night time or weekend, then consult the urgent 24-hour GP to come and change the catheter. So this slide illustrates that you need to teach them almost what a second-year medical student and nurse knows in terms of physical examination. You've also heard that we were talking about 24-hour nurse and the 24-hour GP. So there are some logistic manpower issues that go into prepping for home emergencies. And in our case, actually, if the nurse comes, the family should have a set, urinary catheterization set with the lignocaine jelly. The GP may bring everything. So all these needs to be considered if you are teaching your patient and family. Okay, so I end with this slide. So it shows networks. So when I went to France for my training in 2010 in home ventilation, Dr. Jesse Gonzalez, he kept talking about networks, réseau. That was the term in French. I didn't know what he's talking about. And over the years, I realized the wisdom of that. Actually, the patient and family is at the center of everything. We, the chronic ventilator doctor, we are here, but you cannot serve and look after a patient family alone. So there's a whole network. So within my public hospital, I'm friends of all the specialists, cardiologists, gastro, ENT, urologists, endocrine psychiatry, and I would tap on their experience and wisdom. So, I can informally consult them and if necessary refer my patients to them. But it's so hard for the patients to come back. So usually we have one or two specialists who are very kind and willing to give advice and not so scared of medical legal liability. And what I do is that normally I'll tell them, I will take responsibility. I consult you, but I don't write your name. So, and I tell the patients that I said, do you want to come back and see a specialist? You end up seeing 7 specialists. You spend $200 per ambulance ride to and fro, 6 hours to come to a clinic to see, or you trust us, we will do this for you. So a network of physician specialists. We need the patient. We, of course, here I also have my nurse and therapist. So the chronic vent doctor works with a team of physio, speech, occupational therapists, and nurse, right? Then we have to link up with private GPs, link up with private home care nurse agencies to support the patient and family if needed. The equipment vendor is actually very central because both the patient and family will call the vendor directly if they know there is an equipment problem. We may call the vendor if we identify the problem, and so on and so forth. And sometimes, the domestic worker agency, home care agency, I don't know whether in Malaysia and Indonesia you have this, but in Singapore, we are beginning to see agencies like Homage, or Jagami, and so these are agencies that provide manpower. So sometimes if the patient's family, suddenly somebody is sick or the helper runs away, then you may need to be able to tap on this. We currently don't have a link directly with the domestic worker agency. So it goes through the patient and family. And then even the undertaker, if the patient has passed away. So I don't know about Malaysia and Indonesia, but in Singapore, for COVID, there is a lot of trouble if you are diagnosed with COVID and you can't handle the deceased person's body. So this is the whole network that is very important for our van users. Apparently in Singapore, the undertaker now has links with the private GP. So if somebody passes away, calls the undertaker, they can call the GP to come and certify death.
So, hi, I'm Lydia, the nurse, one of the 3 nurses in this home ventilation service in Tan Tock Seng. And I think Dr. Chan has mentioned quite a bit about the emergencies at home that we have been experiencing. But today I'm going to just touch on how do we prepare patients for home and what are the emergencies that actually nurses will encounter as well, which probably not so much of the medical aspect. So the caregiver, for our group of patients, the caregiver has to undergo caregiver training in the hospital. And the caregivers trainings are usually provided by the nurses and the different therapies, such as the physiotherapy teaching how to do the cough assist and the suctioning, and occupational therapy teaching how to transfer their loved ones safely and prescribe wheelchairs, hospital beds, and things like that. And the respiratory therapies will cover the ventilator aspect. And the nurses will then touch on the general basic care. But also do highlight that, because our regimental kind of schedule within the hospital, like 8 o'clock, you start sponging, cleaning, oral hygiene, then followed by medicine, followed by things like that. It doesn't really happen at home because the caregivers are unable to work through the day, 24 hours, when there's only 1 or 2 of them, and they got to do this for 365 days. So we have to, the trainings the caregivers have to know the rationale behind all this kind of care and adjust the care accordingly at home. So I met with many examples because of the limited manpower and the equipment, cough assist are usually done at twice, 2 sessions per day by the physiotherapists in the hospital. But the caregivers will have think that, go home, I only do twice a day of cough practice. Despite my loved one would need more than that. So because they say that the physiotherapy said so, they only come twice a day. And this can be quite dangerous, because if there is secretion blockage and things like that, they only think that the cough practice is being done twice a day. You can do more than that. So we always reinforce that. That's why there's this we need to come in and rationalize all this nursing care with them, and help them with their planning in their daily activities. So sometimes then they will say that the trachea will need 2 to 4 hours suctioning, right, by the nurses in the ward. They will do 2 hours suctioning for every turning that they do. They will do a suctioning just to make sure that phlegm is clear, so that the patient won't bother them throughout the whole shift with their secretion. Then the family will even wake up in the night 2 to 3 hours of suctioning. Then at the end of the day, they'll tell you they are very tired. Is there a nursing home for them? So there are also caregivers who also require additional sessions. So we cannot expect that everyone will be have well-versed and with everything that we mentioned, right? And most of them would require a lot of caregiver training sessions, that what we usually think that they would require. So we have to be patient. So exactly what did they learn? They learn a list of care tasks, and depending on the needs of the patient, and the duration usually takes about 2 to 3 months for tracheostomization. And even NIV patient will also take 1 to 2 months, because other than ventilator, there are other things to learn as well, including how to care for them and when they're in bed bound state. So the fastest that we actually seen with a very, very involved family was 3 to 4 weeks even. So for someone who has a tracheostomy, these are the care tasks that you have to do, from the TOBI to the basic hygiene, how to change your loved one while they are lying on the bed with the bed sheet. Does all the doctors will know how to do that? May I ask? Can you all change someone on the bed sheet without staining, or even make them neat and clean without falling off the bed? So it's something that the nurses will come in and teach them, and how to clean the backside, that then all the stool doesn't splatter all around the wall and on the bed. So this also needs some training, how to feed, monitor blood pressure, vital signs, and troubleshoot on ventilator alarm, set up TOBI, and the list goes on. So these are usually one of the few, I would say, basic topics that we want a caregiver to undergo during the training in the hospital, like the care of ventilators, like troubleshooting, emergency, especially the trachea dislodgement, blockage, ventilator failure, how to embed back, and how to prevent all these emergencies from happening. And trachea care, how to wash inner cannula. Sometimes they don't even wash up. You'll hear them washing inner cannula, or they tell you, I change the inner cannula once every 3 to 5 days. And that is horrible. You'll be in shock. So, and how to perform secretion clearance with cough assist, and how to monitor their loved ones, which is very important, as Dr. Chan mentioned, and tube feeding, care of feeding tube, and how to transfer. Then how about for someone who is on non-invasive ventilation? So for them, it's also almost the same thing, but just that they probably don't need to learn so much about the tracheostomy portion. But we also got to keep in mind that as patients with motor neuron disease, the respiratory needs can be harder to support towards the last stage, and as a progressive respiratory muscle weakens. So the training of the caregiver will still have to be pretty much similar to someone with a tracheostomy tube. You still have to teach them how to embed back, if the ventilator fails, if someone is on a 24 hours ventilator, or if the person is choked on the food or saliva, how are they going to do that at home? And these are some of the topics as well as mentioned. So this is the ventilator. It's in our video, and this video is in our mobile app, HomeVent mobile app, and we teach them how to, if the ventilator fails, how are we going to embed back through with their mask, and call the vendor for a replacement of the ventilator. So from the list above, you may realize that the learning curve for our caregivers can be very steep. Our caregivers ranges from young to adult, or with different educational background. So both caregivers and the healthcare workers have to work together to ensure that their training is smooth. And so the caregivers have to take notes, do pre-reading of the training. And so on the right, you have someone who is, on the right, you have someone who had some handwritten notes. But this caregiver is quite educated, and she will draw and write in English. But I have others who are, more of like, not so, doesn't receive so much of education. They will be struggling with all these very intense topics, such as how the ventilator work and what should they do with the alarm. So we have to simplify some of these topics for them in layman, as what Dr. Chan has mentioned. So we even have to modify something on the left, right? We have to modify our teaching materials so that we can illustrate the effect of the embo bagging. And we will ask them to download this home band app with there's a video in the YouTube for them to learn, so that they can refer whenever they need. So after all the caregivers underwent the training in the ward, so my colleague and I will be testing them. So test sounds like a very serious affair, but actually we just want to make sure that they are able to manage all kinds of scenarios at home. Like what's the response if they notice there's a drop in the saturation, and what to do if the ventilator fails or beeps. So the learning steps in the daily routine are easy in the day-to-day, but if they require some critical thinking to troubleshoot certain scenarios, they might fumble and they might panic as well. So, but then, so in the end, there was many that could also land up in trigger to ambulance to go back to the hospital unnecessary. There are some necessary and some unnecessary. Yeah. So as a human, we also know that we also tend to panic, right, during our advanced ACLS, BCLS, assessment, and we tend to forget the steps as well, as we don't practice often. If we don't practice often enough, so we actually encourage them to actually have some printout, write in their own notes, and put all these emergencies scenarios at home and how to troubleshoot them on the wall, so they can refer whenever they met with such a scenario. Another point is we have to ensure that the patient is discharged with adequate equipment. Many of times we encounter colleagues asking us, or if the patient is not on mobilizer or cough assist machine, or even oxygen concentrator, why do we have to make sure that they go home with that? But we have to keep in mind that, if a person is at home, we want to try to prevent admissions into hospital unnecessarily. And vendors are not able to support 24 hours times 7 or deliver some of the equipment overnight, like 2 a.m. in the morning. We have to make sure that all these equipments are actually standby at home. So if event that they phone us, we can tell them, oh, you can, start some 2 liter oxygen. They have something to use. And there's some financial aspect in this whole equipment purchasing as well. It's not that cheap for them to fork out money. Just like, like a cough assist, it's a $5,000 to $6,000 Sing dollars. It can't be like, oh, 1 weekend I decide that I want to buy a cough assist machine and the vendor just deliver like that. So that in Singapore, there are some financial assistance, and usually this needs some time for planning and to get it granted as well. Traditionally, as mentioned, we also focus on very much on nursing care. The nurses in the ward doesn't really sit down with the family or talk to the family what's the rationale behind all this care. So we have to again reinforce that we have to teach them what's the rationale behind all this, so that as they move along, they can think and include certain troubleshoot certain aspects from the training that we have done with them. In home band, we also always advocate for family involvement. Many in Singapore, we rely quite heavily on paid caregivers from our neighboring countries, and our family member will be out working and leaving all the care tasks to the caregivers. But when there is emergencies at home, such as, emergencies, I'm saying about social emergencies, like our caregiver can go off day, and someone even got COVID, and they need to be on quarantine order. And they'll be, if you have 2, then you still can rely on 1. But then if the only caregiver, right, caregiver is out, then who is the one who's going to take care of patient? Is everyone going to return to hospital? Are we going to, then with the pandemic, the hospitals are also rather full. That's why we always encourage family to be involved in the day-to-day care and know what is the care like. So in the event that things like that happen, they could stand in as well. So many families actually sought this help from us during this period of time that their helper to all run away or even wanted to go back to return to their own country because of homesickness and things like that. And they always want us to find a solution for them, but we don't have any solution at all. Hospital, we know that the hospital are full to the brim, and there is a long waiting time for new caregivers to arrive in Singapore. And even I would say that the private nursing agencies are also very swamped. And to be honest, they are quite costly, like probably $25 to $30 per hour. How many hours can a caregiver be how many hours can you employ, or how many days can you employ? So family members will have to stand in at this point. So other emergencies, as mentioned, will be encountered through our telephonic support, would be like all these choking, obstruction, that's laryngeal spasms, desaturation, ventilator failure, or even acute abdomen. They'll tell you that my stomach is very, very painful. But is it for every acute abdomen, are we going to trigger back to the emergency department? So we have to screen through and make recommendations, and the list goes on. And so which I think that the caregiver training in terms of asking them how to monitor the signs and symptoms, how to do checks there, our eyes, our ears, and our hands even. So we have to rely on many kind of. So for me, right, we rely mainly on WhatsApp chats with them, and sometimes I will have to find YouTube video how to check for pitting edema. I have to try, then I have to find a video. I say, hey, follow, you read through this, then you let me know if there's a pitting edema, or I have to take a video of myself resting on my leg for 10 seconds and see if there is. So there's a lot of also guiding through photos, and even I use quite heavily on home band app to show them which video to watch and what is the time, even like you watch from 1 minute and 3 seconds onwards to how much, so that they have a better idea how to manage certain scenarios at home. We are also trying to move towards Zoom kind of teleconsult officially, but we are still not able to move very much there because traditionally we are relying on quite a bit of WhatsApp kind of like calls and even videos. So do we actually and all these kind of teleconsults, right, we usually need to be paid, and whereas our consults telephonic all along have been always quite absolutely free. And why would our family want to pay for that teleconsult? We are still trying hard to work towards that. Other than preparing patients for them at home, right, emergencies at home, we also need to think about preparing emergencies outside of home. So we cannot say that they will stay at home all time, all the way till the end of life. So many of time they will still need to go back for appointments, to our home, attend weddings, and things like that. So the caregivers are advised to bring the necessary equipment and requisites if they are bringing the patient out of home. So scenarios like the ventilator failure while being stuck in the lift or stuck in the jam, or trachea dislodged, if someone had tripped over the ventilator circuit, so what would they do? So if they are going to, so despite nagging, despite showing them, many of them just don't want to bring so much of equipment because they think it's a hassle, and they will just bring a ventilator and when they encountered something on the way, then they'll be panicking again. So it is something that we want. So we always reinforce to them that all these are necessary. We just have to anticipate the worst scenario, and we don't want to regret. Better be safe than sorry.